available, high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available. But please use the all-access pass if you need to claim CME credits. Thank you so much.
And we're live in 5,
4, 3,
2, 1.
Well, good morning, everybody. It's February 7th, 2025, and this is Jens Chapman from the Seattle Science. And it's a special pleasure to congratulate and thank our colleagues from UCSF, one of the premier spine fellowship programs in the country, if not the world, to this topic today. Before we go ahead and pass on to Dr. Alekos Theologis, who is going to run the show today, with his terrific team. I wanted to give a shout out to Dr. Vidyatara and his group, Dr. Vidyatara and his spine video team from the Manipal Institute of Robotic Spine Surgery in Bangalore, India, have joined us with their group, and we're really excited to have them and look forward to future collaborations. Today's topic is particularly relevant. As I just insinuated, UCSF has done more than, I think, just about any program in the world about understanding and helping us pragmatically cope with spinal deformities and how to do it as good as possible, understand it better. And I want to thank Dr. Theologis to take the lead on today's program on how to do these surgeries safely and efficiently. And I'll pass the microphone on to Dr. Theologis virtually to introduce his team. Thanks for doing this, and thank you all around the world for joining us.
Thank you, Jens, and good morning, everybody. Thanks for having us again. We love these topics and venue. So as you mentioned, we'll be talking about staged versus single-day anterior versus posterior operations for adult thoracolumbar deformity. And we have a wonderful cast. We have 3 of our fellows, Austin Katz, Asra Tubaye, Abdullah Al-Shamari, and one of our fellow chief residents, AJ Aga, who will be doing his spine fellowship in San Diego next year. We'll have moderation by my partners, Sigurd Bourbon, Shane Birch, and Lionel Metz. And because we have a short amount of time, let's just dive right into it. And we'll start with AJ. Feel free to share your screen. And Dr. Bourbon will be moderating this.
Right. Hi, everyone. Can you hear me okay?
Yes.
All right. So thank you all. I'll be presenting the paper from Stanford titled Short-Term Outcomes of Stage First to Same-Day Surgery for Adult Spinal Deformity. This is a paper out from Stanford. Thank you all for listening. So just to get started, as you all know, adult spinal deformity surgery is highly invasive often, utilizing multiple approaches and surgical techniques to achieve a desired durable correction, often with the goal of circumferential fusion at multiple levels. This type of surgery is complex in nature, not only in its application, but also with regard to the patient population baseline comorbidities, spinal alignment profiles, as well as their post-op care management. Because of this, there's been multiple studies dedicated to kind of look at the complication rates in this population, and many of them have found quite high rates, some as high as 80%. These include, but are not limited to the list that you see there, and these include PE, myocardial infarction, neurologic injury, and many of these are associated with increased ICU admissions as well as lengthy hospital stays. Given the complication rates, the staging of these procedures has often been employed as a method to theoretically mitigate the risks by allowing the patient to recover and to be optimized in between stages. However, studies on these staged strategies thus far have yielded mixed results, especially in terms of their longer-term intervals, like 5 to 7 days. Therefore, the aim of this study was to evaluate and compare complication rates and outcomes between the interval surgeries with 3 days or less compared to same-day surgery. The authors hypothesized that there would be similar outcomes with no increase in complication rate in the stage group. Here's the method slide. So in terms of the methods, this was a retrospective cohort study of patients undergoing both anterior and posterior base surgery, including lateral procedures from 4 surgeons from a single institution. The table here lists the inclusion and exclusion criteria. Patients with any traumatic, malignant, inflammatory, or infectious etiologies were excluded from the analysis. And their final numbers, they had a total of 92 patients, which were included, and those were about split half and half for the stage versus the same-day surgery. The primary outcomes are listed, and these include complications within 30 days, readmission, length of stay, total operative time, EBL, PJK, pseudoarthrosis, and neurologic deficit. Secondary outcomes included the anesthesia time, transfusions, the use of any clotting factors, ICU days, as well as reoperation within 6 months. In addition, the baseline demographic data and surgical details were collected. Pre and post-op spinal correction parameters were also compared between the groups, and both univariate and multivariate analyses were ran. So let's jump into the results here. To start, there were no baseline demographic differences between the groups. The majority of the stage surgeries happened within 2 days, with the upper bound being 3 days. In the stage group, there were significantly more anterior approaches performed, as well as an increased rate of osteotomies, decompressions, and a greater number of posterior levels fused. There were no differences in the discharge disposition between the 2 groups. On this slide, we see some of the data from the univariate perioperative results. On the table on the right there's for the length of stay for the stage procedures, there was nearly 3 days longer, at 9.2 compared to 6.3 for the same-day surgery. Operative time, anesthesia time, and EBL were all significantly greater for the stage group in this univariate analysis, which is somewhat to be expected. However, when the multivariate analysis was ran for length of stay, the stage surgery length of stay was only 0.8 days longer than the same-day surgery, which was not significant. And this indicates that the difference seen in the univariate analysis was driven mostly by the inherent intervening days between the stages and not an additional kind of penalty in days after that. In addition, when multivariate analysis was performed, the increase in EBL was driven completely by the difference in operative time between the groups. Secondary perioperative outcomes such as blood cells, platelets, and clotting factors used, as well as days in the intensive care unit, were also greater in the staged group relative to the same-day surgery, with a p-value of less than 0.001 for each of those. However, they did not report the exact values in this paper. When looking at reoperation, readmission, and any complication, there were no significant differences in rates between the stage patients and the same-day patients. However, there were more instances of dural tears and DVT-PE in the stage group. Interestingly, the rate of the DVT-PE patients who underwent ALIF was 7.6%, whereas in patients who did not have an ALIF, it was only 3.8%, indicating that there's potentially an effect there. However, the study was underpowered to assess for any significance of these findings. So it's possible that the rate of the DVTs is just a function of retraction of the great vessels in an anterior approach, as we might expect. Additionally, there was a trend towards neurologic injuries in the stage patients, but that was not significant. Here are the radiographic outcomes. There were no pre-op differences in parameters between the groups, but those in the stage group had significantly improved pre versus post-op measurements of pelvic tilt, lumbar lordosis, and their PI-LO mismatch compared to the same-day patients, suggesting that a more powerful correction was achieved in the stage patient cohort. In the PI-LO mismatch and SVA results, the post-operative stage patients also had significantly lower values when compared directly to the post-op same-day cohort, as designated by the cross symbol that's highlighted by the green arrows there on the slide. Another way of demonstrating this finding was utilization of the Schwab sagittal modifier grades as defined by the table on the left, which categorized the degree of sagittal measurements from 0 to 2. As you can see in the table on the right, the staged patients were more likely to have a greater degree of change in their PI-LO mismatch as compared to the same-day patients, again indicative that a more powerful correction was achieved in these patients. This is likely the result of the greater use of osteotomies in the staged patients that was shown on the table previously. So in conclusion, this study demonstrates that staging of 3 days or less did not result in a further increased length of stay beyond the stage duration. The EBL increase in stage patients was a result of longer overall operative times. Overall complication rates were similar between the groups, with statistically higher rates of dural tears and DVT-PE in the stage group, which is likely driven by more complex surgery in the stage group in terms of number of levels fused, the rates of osteotomies, decompressions, as well as the anterior approach utilization. Greater corrections were achieved in the sage group, which again is likely a function of some of these factors, such as the osteotomies and posterior levels fused. So this is overall a good study, but there are some limitations to it. These include that this is a retrospective data set at a single institution, and there may have also been biases in terms of surgeon preference, in terms of approaches utilized, as well as correction goals. Also, there are baseline differences in surgery characteristics between the groups, as I mentioned before. These may have skewed these results. The follow-up period for complication capture was only 30 days, which is quite short and a little bit odd considering all the patients had at least 6 months follow-up to be included. And albeit the goal of the study was short-term outcomes, but some of these complication rates, such as PJK, pseudoarthrosis, infection, these often present beyond the 30-day threshold. Therefore, it's unclear. Also, it's unclear at which point times they are measuring these sagittal parameters, and based on over time, these may change the results as well. They also did not state the exact number of ICU days. They only reported the significant p-values, but that might be a significant difference between groups that may be worth further investigating. However, this study, I think, does provide evidence that a shorter staging period of 3 days or less, especially for more complex cases, does not seem to incur a large increase in complication rate, often associated with longer length of stay and other periop considerations. In addition, it provides more evidence that same-day surgery is often relatively well tolerated for many patients undergoing ASD surgery. So for my practice in the future, I think this study may help inform what I set or aim for as an upper bound of days between operations for my ASD patients who undergo stage procedures, as well as inform these patients of the potential risk of each timing strategy. Thank you all for listening, and welcome any comments.
AJ, that's a terrific overview of that study. Maybe you just leave the conclusion slide up there, or we'll discussion.
Yeah, let me put it up there. Yeah.
So I think there's a lot of variation, and when we think about deformity surgery, there's a terrific amount of variation in the techniques that we use, anterior versus posterior only approaches, and in staging strategies. So I think this topic overall today is a really important one that highlights some of this variation. And as you pointed out here, a big part of what we see, certainly in our practice, is surgeon preference, right? There's a lot of surgeons who prefer to stage surgeries and not to. One of the troubles I've always had with staging surgeries is that we're really reaching beyond 3 days, kind of a physiologic nadir for the patient, meaning that it's only in the 3 to 5 to maybe 7 day period that patients are really running down on their serum albumin. Sometimes the drop in crit and transfusion requirement may occur in a couple of days after surgery. And I thought some of the complications you pointed out were interesting. DVT and PE rates being higher in stage group, that's certainly concerning. You pointed out the confounding factors at the complexity of surgery. What do you think is the threshold, AJ, of how much time, how much blood loss is it acceptable to do a same-day surgery versus where's the threshold where you might think about actually staging an operation in terms of complexity or blood loss?
Yeah, it's a great question. I think obviously there's some big, intraoperative, let's say, complications that if they were to arise, that I think would necessitate staging or even maybe aborting it. Like essentially, if you had, an injury to the great vessels or anything like that during an anterior approach, that certainly would be reason to just pause and make sure the patient is resuscitated and stable for the second stage. And then I think, when we start getting into, multiple liters of blood loss, that may be another reason why I would maybe decide to wait and stage the procedure and make sure that their hemoglobin is stable, or at least not requiring additional transfusion. And then also, I think like length of operation, if we feel like the surgery is going on for quite a long time and having a patient prone for, or in one position for a very long time, it may necessitate that, this might be reaching kind of a physiological limit for this patient to be stable. And then again, also just using any of the kind of anesthesia their input as well. If the patient is becoming unstable or seems showing signs of having kind of respiratory issues or whatnot, that may push me to hit the brakes and put the case on for another day for the second stage.
Yeah, I think you highlighted some good ones. So I'll just briefly add that probably the most common reason that I stage is if I'm going to get a posterior correction of my deformity, typically with 3-column osteotomy, and then if subsequently I want to plug the anterior column, that's something I might stage. I might even stage it 4 to 6 weeks down the road rather than do that right away. But Jens, you had a comment or a question.
Really good article. Thank you, Dr. Aga. And again, the topic overall is so important. So methodologically, Dr. Aga, the first question is comparability of the group. There were several insinuations that they're probably not comparable and that there are a lot of subjective criteria involved in this retrospective assignment. So both pathology-wise, patient-wise, et cetera. How disparate are those groups, or how comparable are they actually? The second thing is this ended in 2016 in terms of the enrollment, so a lot of things changed in terms of approaches. Some surgeons now do less invasive surgeries and far lateral approaches, et cetera. Did the approaches, in your opinion, matter?
Yeah, so looking at the slide here, which I pulled up, you can see that there's significantly more anterior surgery in the stage group. And they have different profiles in terms of the complication rates, I think, which are likely a result of the different surgeries that were performed, such as dural tears, DVT. These include, the differences in levels of surgery that they were performed on, as well as osteotomy, decompressions. And so, I think it's good to know that I think these aren't necessarily the most comparable groups in terms of those kind of factors. And in some ways, I think this at least kind of helps me say that even if I do fairly relatively complex surgery, same-day surgery is actually still relatively well tolerated in the population. But to necessarily have a direct one-to-one comparison rate between complication rates, these aren't necessarily the best matched groups, I would suggest, although their baseline demographic data was not dissimilar. So that's the first part there. And then I do think, to your second point, the use of more lateral surgery may kind of obfuscate some of these, issues with blood loss or necessarily having to be around the great vessels, might be safer in that regard, but they may put, patients at kind of higher rates of maybe neurologic deficits, especially, with regard to the psoas muscle and some of the neurostructures and within that muscle and on top of the muscle. So it may, the risk profiles of doing these different type of procedures certainly will be different over time as more lateral surgery is included in these type of stage procedures.
Then I wanted to just add one comment to Dr. Bervin's excellent point about the immune response. So from a polytrauma world, the worst time to do surgery is probably 72 hours out. If we see major spine surgery as a traumatic event, which it undoubtedly is, our T and B cell lymphocytes go down brutally after 24 hours, and by 72 hours, they kind of hit a low point before they start building up again. So as we stage in a trauma situation, the 72-hour mark is probably the worst. So staging it where you actually send a patient home if you have an anterior column reconstruction, if you're comfortable with that, or doing it rapidly, like within 24 hours, if physiologically acceptable, might be better. Any thoughts on that, Dr. Bervin?
Yeah, I think you're right on target there. Yeah, that's exactly where I think that this staging point is probably the least appropriate in terms of physiologic nadir, as you point out, lymphocyte count, serum albumin, clotting potential. All this is at a nadir. So if you're going to stage, perhaps even a longer staging period might be more appropriate. And I think we should go on to Austin's paper next, because just in the interest of time, part of the discussion we'll have perhaps later after one of the papers is also the economics of staging. So I think from a patient interest point of view, there's a lot of argument for same-day surgery. But Austin, why don't you go ahead and take the screen and we'll yield to you.
So Austin's having some technical difficulties. We're going to move on to Asra 2A, and her talk, or her title, her presentation is Comparison of Stage for Same-Day Circumferential Fusion for Adult Spinal Deformity. Asra, go ahead, and this will be moderated by Lionel Metz, I believe.
Yes, thank you. Good morning, everybody. I can Okay. As we all know, adult spine deformity is increasing in the aging population. In terms of corrective surgeries, as mentioned before, we have the option of stage versus same-day surgery for circumferential fusions. There is variability in decision-making. Some surgeons, in theory, decide to do stage surgery with the thought of minimizing the morbidity associated with the length of the surgery, and some surgeons prefer to do it as a stage surgery to decrease the total operative time, blood loss, and the anesthesia side effects. The objective of this study was to analyze the differences between intraoperative and postoperative complication profile, length of stay, readmission rates, discharge disposition, cost of stage versus same-day complex surgeries in adult spine deformity. This was a retrospective review at a single institution. In terms of inclusion criteria, they only included patients undergoing combined ALIF and posterior spinal fusion. Any other approach, anterior approach, any other non-anterior approaches were not included in the analysis, as well as neoplastic, trauma-related and infection-related surgeries. In terms of study variables, they collected patient demographics, intraoperative complications, postoperative complications, readmission, reoperation, and hospital length of stay, as well as hospital admission costs. In terms of statistical analysis, there were two cohorts that were analyzed. One is the entire cohort, and the other one, they only looked at the long segment cohort. This means that they only looked at, in that cohort, they only included patients that undergone more than 4 levels of posterior spinal fusion. For analysis, they performed inverse probability weighing analysis to control for the number of levels fused, both in ALIF and PSF, as well as some of the patient's characteristics. When I report that, as well as when they reported both unadjusted and as well as IPW model analysis. In the total cohort, there were 211 patients, 50 were staged, and about 160 were same-day surgeries. In the long segment cohort, 100 patients were identified, and almost 50-50 were staged versus same-day surgery. In terms of preoperative comorbidities, in the whole cohort group, there was no significant difference between staged and same-day surgery. But when they ran the IPW model, staged patients had higher rate of COPD. In the long segment cohort, there was no significant difference between the two groups in both analyses. In terms of surgical details, as expected, in surgical details in the whole group, as expected, in the staged group, there were more significant levels fused than same-day surgery. Also in the staged group, there were more estimated blood loss than same-day surgery group. And these differences in level of fusion and estimated blood loss were not seen in IPW. In the long segment cohort, stage group had significantly more levels fused than same-day groups, and the differences were not observed after the IPW analysis. There was no significant differences estimated blood loss in both models. In terms of preoperative complications, in the whole cohort, staged group had higher incidence of intraoperative complications, as well as a higher number of patients with postoperative complications. Stage group had a significantly higher incidence of postoperative PE, altered mental status, delirium, cardiac arrhythmia, and surgical site infections. When they ran the IPW model, only the rate of postoperative PE remained significantly higher in staged group. In the long segment cohort, there was no significant difference in the incidence of intraop and postoperative complications. And then when they ran the IPW analysis, there was still significant difference between the groups in terms of higher risk of PE in the staged group. In terms of length of stay, in the whole cohort analysis, both unadjusted and IPW analysis, there was a longer length of stay for stage group. Also, this was true for the long cohort analysis. In terms of reoperation and readmission rates, in the whole cohort group, the total reoperation was higher in stage group, but this was not significant after running the IPW analysis. In the long segment cohort, there was no significant difference in readmission and reoperation between the two groups in both models. Finally, in terms of the cost, in the whole group analysis, in the whole group analysis, in the whole group analysis, in the unadjusted, mainly unadjusted analysis, stage group had higher costs associated with the surgery compared to the same day surgery. And then when they ran the IPW model, still stage group had a higher cost associated with it. In the long segment group, in the unadjusted model, stage group had higher cost associated with it, and same thing was true when they ran the IPW analysis. In conclusion, we see that stage procedure in adult spine deformity were associated with higher rates of pulmonary embolism and longer hospital stay and increased total admission cost. And IPW adjustment also confirmed that stage groups still had a higher rate of PE and longer recovery. Obviously, this study had some limitations. This was a retrospective study, and obviously not randomized data. It was based only on one single institution. The sample size was small, especially in the subgroup analysis, mainly in the long segment cohort. And obviously, it would be interesting to see the patient-reported outcomes in the analysis to analyze this based on how patients feel after stage versus same-day surgery.
Great review, Asra. I think overall, my take-home points, maybe we'll put back your conclusion slide again.
Sorry.
The take-home points, I think, are, for me, the PE consideration, pulmonary embolus consideration, I think is probably what struck me the most. When we think of Virchow's triad, endothelial injury, hemodynamic stasis from our patients being recumbent and not mobile after that first stage, and hypercoagulability, at least those first two are really coming into play. That in the setting of the increasing inflammatory cascade, particularly after that 24-hour period. We know from the femur fracture literature that if you get to patients, their second trauma is the femur fracture fixation. And so when you get to those patients within 24 hours, they do a lot better in terms of thromboembolic events and mortality. And so I think of the stage cases as sort of that second trauma that if you get to it within 24 hours, you're probably better off than delaying, 48 or 72 hours. But again, the PE thing, I think it can't be understated. And that's something that really we don't have a good way to mitigate, because most of us are not anticoagulating between stages. I think overall, unless you have a randomized controlled trial, you really are going to be missing some subtle variables that are not captured even in the best post hoc control or best post hoc matching. The number of segments fused does not really describe the severity of the deformity or what you have to do to achieve your goals. And so I think really to answer this question, we would need a randomized controlled trial in the future, most likely. And then again, the cost I think is important, but probably not as important as complications when we're thinking about these big reconstructions.
Dr. Tubai, this is Jens Chapman in Seattle. Thank you so much for a really cool take on this important topic. If I may ask you and your attendings, you have, again, a highlight of seriously high-powered surgeons in your program. Is there a consistent VTE prophylaxis program for your deformity patients? Do all of you have the same kind of anticoagulation protocol, let's say 24 or 48 hours out? Is this something that is consistently handled? Because that's, I think, what Dr. Metz said, the critical part here, anticoagulation between stages.
Asher, why don't you take a swing at that, because you write more postoperative orders than I do.
Yes. Base one, I have seen there is differences between the different attendings. Mostly, we don't anticoagulate patients postoperatively or in between the stages. Basically, it would be mechanical kind of SCDs, unless after a few days they're not able to ambulate. Only one of our surgeons, I think Dr. Theologis, anticoagulate patients after 2 days. The rest, we don't anticoagulate.
Because Dr. Abdul-Jabbar wrote a paper where we looked at 24 hours or later, and do you want to just tell them what you found, basically?
Yeah, no, I think that it's a highly variable, and in the data out there, is in spine is nowhere close to what we have with total joints, and clearly you want to be anticoagulating. I know all of us here do, and depending on the case will be either 24 or 48 hours for my patients, and I think you guys are more 24. So it's really institution specific. I know here in the ICU we have a very strong push towards anticoagulation, and that's kind of trickled down to us in the spine group. But yeah, I mean, that study, I was not on that study. Which one were you talking about, I think?
We did a large retrospective review, and I thought you were one of the authors of it. I apologize.
I don't think so.
It was 24 hours was basically safe for major spine surgeries, but those all-comers take not included oncologic patients and deformities and infections. But yeah, some of us were way late, like 72 hours, and so we did the comparison study, and we found no adverse events. They are evenly, the bleeders were evenly grouped in both categories.
And surprisingly low rate of post-op hematoma, from what I remember. I think I know what you're talking about.
They would happen if they wanted to happen, and they would not. It was not dependent upon our anticoagulation protocol.
Yeah, what do you use for your protocol?
We basically, I think, Amir, we start after 24 hours unless we have some serious...
in terms of what agent?
What agent, yeah.
Lovenox, sorry. So reversible agents.
Okay.
Typically use enoxaparin as well?
Yeah.
That's been my experience. So I usually will do all these on single days, and I'll anticoagulate on post-op day 2, and knock on wood, no issues. If I do stage, talking with the vascular surgeons, they start Plavix and aspirin after major anterior reconstructions of the aorta. So if I do an ALIF, I'll start Enox post-op day 1 between stages, and I haven't had any retroperitoneal hematomas. So I personally think prophylactic anticoagulation is safe. The real issues with hematomas, et cetera, is around therapeutic anticoagulation.
Yeah, there's a real controversy if we're going to use anticoagulation, what to use, because I agree that the trouble with Lovenox is that actually there's a specific warning about Lovenox for epidural hematomas, and so perhaps using heparin at 5,000 units BID versus Lovenox, I'm very cautious about, because there's a specific warning. I've actually had a patient with an epidural hematoma that we captured early this year with Lovenox, and that's where I stopped using that.
Yeah, I agree with you, Stig. I think that anecdotally, I've seen much more sort of seroma and hematoma formation, or just steadily dropping crits with Lovenox than I have with unfractionated heparin. So I've gone to 5,000 BID for patients below a certain weight threshold and TID above that weight threshold.
it's interesting, if you do heparin, it's easily administered in the hospital, but once the patients go home, at least around here, it's very hard to get insurance approval or for the patients to get it from the pharmacy. So if you want to anticoagulate them longer than their inpatient stay, then doing heparin is more challenging. I do enox for 2 weeks after surgery, and again, knock on wood, no issues.
I think in general, we're dealing with pretty small numbers. John Grauer did a really nice systematic review with NAS on this, and really not a great conclusion. In the high-risk patients, the patient that I specifically used, the Lovenox on, had a history of AFib, history of DVT, and a factor Leiden deficiency. So in that patient, I did use it. But in general, I think early mobilization is what I've been using. And early mobilization requires a lot of surgeon engagement, and that's been difficult, quite honestly, with regard to some of the changes on floors with traveling nurses. But early mobilization, I think, is probably the most valuable thing for patients who can mobilize after surgery, other than perhaps our trauma patients or oncology patients.
I agree. Last comment before we move on to the next one. I do think that prophylactic anticoagulation between these stages after an anterior approach is safe. So I think the discussion about anticoagulation after posterior operation with epidural hematomas is a different one, but getting a hematoma after ALIF is exceedingly rare, given that we don't take down the PLL routinely. So I think if we are going to stage operations, that doing it between stages, in my experience, has been safe. And I think from a vascular surgery standpoint, they're okay with it as well. So the next one will be given by Abdullah Al-Shamari, and I'll be moderating this. So Abdullah, take it away.
Sorry, Azra, do you mind just sharing your presentation?
I unshared it. Yeah.
Okay, thank you. Good morning, everyone. Today I'll be presenting a study titled Comparative Safety of Simultaneous End-Stage Anterior and Posterior Spine Surgery, published in Spine Journal in 2012. And the study examined the preoperative outcome in circumferential spine fusion procedure performed either simultaneously or in the stage manner. So circumferential spine fusion has increased the risk of preoperative morbidity and mortality compared with a procedure involving one side. It's often performed in cases of trauma, scoliosis, and degenerative spine. Surgeon can perform this procedure in 2 ways, either simultaneous surgery where both anterior and posterior fusion procedure are completed on the same day, or in stage fashion, which the anterior and posterior fusion are done in separate days during the same hospitalization. And the rationale behind that is when you stage the procedure, it's minimized the preoperative risk. However, there's uncertainty whether this approach truly reduces the complication or if it introduces new risks. So the study objective and the aim for this study was to compare the preoperative outcome of simultaneous versus stage circumferential spine fusion in terms of complication rate, mortality rate, and risk factor associated with mortality and morbidity and mortality. So the study design and for method, it's a retrospective study analysis, and the data source was collected from nationwide inpatient sample, and data was collected between 1998 and 2006 were analyzed, and the patients and the sample size was 11,265 patients, and the comparison group in the simultaneous surgery group, 71% of the cases, and in the stage group, around the 29% of the cases in that group. And for patient characteristic in that study, so the average age for stage surgery group is 43 years, and spontaneous surgery is 45 years. And also they found in terms of prevalence that in the stage surgery, they have that the prevalence is higher in patients with emergent admission, deformity, or trauma cases, also in rural center or patient with a private insurance. So the study found several important findings that complication rate in the staged surgery was around 28%, and the simultaneous group was 21%. But there was no difference in the mortality. There was no difference in the mortality between those two groups. And stage procedure group had higher rate of venous thrombus and adult respiratory distress syndrome. And overall complication was higher in the stage procedure group, and some of those complication was device-related complication, respiratory complication, and preoperative anemia. And the study identified several key risk factors for adverse outcome. Patient factor age more than 65 found to be has a higher risk of complication and mortality. And patient with the diagnosis of scoliosis or oncological spine had worse outcome. And for hospital factors, they found that large hospital and rural center report higher complication rate. And for comorbidity associated with increased risk were pulmonary circulatory disease and coagulopathy. So the study findings suggest that simultaneous circumferential spine fusion did not increase the mortality and may actually reduce the overall complication rate compared to stage procedure. Simultaneous surgery were associated with shorter hospital stay, on average 3 days. And one of the most significant implications that stage procedure expose patient to additional risks such as prolonged hospitalization, as mentioned, and increased susceptibility to venous thrombus and respiratory distress. From a healthcare perspective, stage procedure also contributed to a higher cost due to the extended hospital stay and increased rehabilitation need. These findings suggest that when feasible, simultaneous spine fusion may be preferred to minimize the morbidity. The limitation of the study, despite the value and insight this study adds, it has several limitations. Start with its retrospective design and potential for selection bias, and data source limitation because it lacked the information on post-operative discharge complication and does not account for specific surgical technique, blood loss, or operative time, and no causal interference that the study showed. And the study only established association and no causation. Conclusion, the study suggests that simultaneous circumferential spine surgery did not increase the mortality and may reduce the complication compared to stage procedure. And a surgeon should consider these findings when deciding between stage or simultaneous and high-risk patient. That concludes my presentation. Thank you for your attention.
Very nice, Abdullah. Nice summary. And I applaud some of my Greek
colleagues out there for trying to answer a question looking at larger number of patients. I think using these types of databases, benefit is the numbers, but there's not a lot of granularity. We don't know exactly what operations were done. And the inclusion criteria here was very, very broad. It was beyond just a degenerative population. They didn't include oncologic cases. They did include infections, emergent cases. So this is all comers. Despite their attempt at a multivariate analysis, I do think that there's some other factors that just weren't able to be assessed here. So, yeah, I think it's nice to put the big numbers, and does somewhat confirm the results of other studies. But I think there's other confounders here that may have not been taken into account.
Let me ask you a question. So when Dr. Al-Shamari, thank you for this nice review. When they talked about simultaneous surgery, we're not talking about same-day prone position surgery through a far lateral exposure for the anterior column reconstruction or a lateral position surgery. This is same-day surgery, right?
Yes. So they basically, in the simultaneous surgery, basically in that group involved doing the procedure in the same day, but they did not mention like doing it in the same setting. But from what I got, like from the study, it's done in the same setting, basically.
Yeah. I mean, nowadays, obviously, industry is pushing very heavily these truly simultaneous surgeries where there's Dr. Abdul-Jabbar has done a couple of those where he does a far lateral exposure to reconstruct the anterior column whilst the posterior surgery is being, quote, simultaneously performed. I'm still not sure what to think about that. Dr. Theologis, in your practice at UCSF with your major deformity procedures, where is anterior and posterior column reconstruction as two surgical entities still the norm, or due to posterior only surgeries, is that still a reasonable approach for deformities?
I would say I think all of us involve some type of anterior column reconstruction through an anterior or lateral approach. The approach for the anterior inner bodies varies. Some of us do direct anterior paramedian supine, others do ATP, others do direct lateral transpsoas. Some of us, and Lionel Metz, who's on the call, has dabbled in the PTP. I'm not sure if he's utilized that for the deformity patients, but we'd run the gamut in terms of the surgical techniques for the anterior column. Lionel, do you want to talk about your experience with PTP, if that's something you utilize for deformities?
Yeah, I do use PTP primarily for degenerative cases, just based on my experience thus far. Typically, when I'm doing a bigger reconstruction, I'm doing a traditional paramedian A-lift and then lateral on day one, and then on day two, doing the posterior. And when I use that combination, I typically will do the A-lift and the lateral in a lateral position, and then posterior is just on day two. So I haven't done as much of the PTP for these bigger surgeries.
I think one of the things that has to be recognized when we talk about these papers is that why we're doing anterior approach, and anterior approach could be a lateral or ATP or direct anterior, and there's three reasons. You're trying to get a fusion, you're trying to get a release, so to help your correction, and you're trying to get realignment. And oftentimes in a deformity patient, you're trying to get one of those three things or achieve one of those three things that might be hard to achieve through just a posterior approach. And so one of the problems with these patients when you're talking about stages is the indications for the surgery and the diagnosis that the patient has, radiographic diagnosis or clinical diagnosis. And so it's it's really hard to match somebody who you're just going to do a posterior approach on versus somebody who you're going to do a circumferential approach on, because it may not just be about getting a fusion. It could be about a release or realignment. And so I think we have to take that into consideration.
I'm glad you brought that up, Shane. So we have 9 minutes left. I think Austin's figured out the technical side of things. And if we want to move on to his, it may be abbreviated, but I think it's worth the discussion. So Austin, feel free to take it away. And Shane, Birch will be moderating this one.
All right. Yeah, sorry for the mix up here. I accidentally managed to put together a presentation for a duplicate article. So I put something together pretty quickly in the interim here. So this project is titled Outcomes of Open Staged Corrective Deformity Surgery in the Setting of Adult Spinal Deformity. As a brief introduction, as we know, spinal deformity is a growing cause of disability. Overall complication rates can range from 40 to 80%, and surgical correction may require a combination of anterior and posterior approaches. And in order to modulate risk, some surgeons choose to divide the physiologic insult and allow initial recovery and resuscitation, whereas same-day surgery may be chosen to avoid potential complications related to increasing length of stay and other complications associated with longer periods of immobilization. As a brief background, the benefits of staged or SDA in this paper surgery has not really been...
Austin, your slides aren't advancing here, so maybe put it on presentation mode.
How about now?
Yeah.
Yes, got it.
Benefits of stage surgery has not yet been demonstrated for the authors, and risks. Debate exists over the risks of stage versus simultaneous surgery. So the objectives here were to compare intraoperative, perioperative, and 2-year outcomes between staged and simultaneous surgery, evaluate complication rates and functional improvements, and assess impact on revision surgeries and quality of life. Regarding methods, this is a retrospective review of prospectively controlled multi-center database from 11 institutions. Inclusion criteria included 18 patients 18 years old and over. They needed to have a Cobb angle greater than or equal to 20 degrees, a sagittal vertical axis greater than 5 centimeters, and a pelvic tilt greater than or equal to 25 degrees. Neuromuscular, syndromic, infectious tumor cases were excluded. And patients followed up at baseline 6 weeks and 2 years. The stage procedure was defined as 2 separate surgical events within 31 days, and simultaneous was defined as a single surgical event. There are a number of radiographic parameters evaluated, as well as patient-reported outcomes. The statistical analyses chosen were ANOVA and t-tests for group comparisons, and complications were analyzed using chi-square. Regarding results, there were 142 patients in total. 71 were staged and 71 were simultaneous. Higher perioperative complications were found in the staged group. This was significant, and higher revision rates were found in the staged group as well. And there was an increase in operative time as well as complexity in the stage group. There was no significant difference in health-related quality of life improvements at 2 years, and there was no difference in patient-reported long-term pain. Radiographic outcomes were similar, and it was noted that for the stage group reoperation, they had a higher incidence of hardware failure, pseudoarthrosis, and junctional kyphosis, whereas the simultaneous group had fewer returns to the operating room due to mechanical complications. The staged patients had a longer hospital stay and ICU admissions, and the simultaneous patients had a shorter initial recovery, but higher early post-op pain scores. So stage procedures are associated with an increased perioperative risk, including infection, wound dehiscence, and DVT. This may be due to extended recovery time between stages. There's increased incidence of revision surgeries, which suggests that initial stage procedures may be less effective in ensuring long-term stability. But this also may have been due to the nature of the complexity of the stage procedures compared to the simultaneous procedure group. Authors have concluded that the stage procedures allowed for division of complex corrections, potentially reducing surgeon fatigue and improving precision in each stage. Whereas the simultaneous surgeries may present challenges in terms of sustaining surgeon focus and patient stability throughout a prolonged procedure. Despite the increased early complication rates, long-term quality of life improvements were comparable between the two groups. And the increased incidence of revision in the stage group highlights the potential concerns regarding durability. Simultaneous procedures may be preferable for patients who can tolerate longer single-stage surgery with fewer perioperative risks. But staging remains a valuable approach for patients with severe deformity requiring extensive correction, or those with comorbidities that increase surgical risk. Future research should evaluate long-term cost effectiveness, patient satisfaction, and biomechanical durability between the two stage and simultaneous approaches. There were some limitations noted. The patients were obviously not randomized. Despite some similarities in terms of the interbodies used in surgical invasiveness, there were notably more ALIS and lateral interbody fusions performed in the stage cohort, which certainly can influence the complication disparities seen. They were also unable to match patients based on interbody levels because of lack of power. So some key takeaways: simultaneous may be preferable due to fewer perioperative complications. Stage may be valuable for complex cases requiring a larger correction. And future research is needed to refine selection criteria.
Thanks, Austin. Thanks for putting it together in pretty short notice. This is the type of paper when you just read the abstract, you're like, well, there's no way I'd ever do a stage procedure because the complication rates are high. The paper, quoted 152% complication rate. But when you actually drill down on the data and they did a sub-analysis, which is buried in the results somewhere, they've actually said if you do a short-term staged, short staging versus long-term staging, the short-term staging is no different than the non-stage group. So they had a huge staging window here between like 1 and 31 days, I think. And there's a bunch of outliers, it seems like, on very long window staging, so like 2 weeks and above. And those are the patients that kind of had the most complication rates. And again, it gets back to, I think, what we've said in the other papers. They're just not the same patients. And so I think they tried to do a good job with propensity matching, but the type of surgical procedures these patients had were different, stage versus non-staged. And then some of these stage patients were staged incredibly, with an incredibly long window between stages. And there has to be something in there for why that happened. Maybe it's an institutional thing, but could be just a patient thing that we're not seeing. So it's kind of hard to really take any true message from this paper. I just don't think that the comparison is very accurate. So I know we only have a minute left, but maybe other people can comment.
No other comments, and I don't want to keep anyone longer than we need to. 7 o'clock, wonderful discussion. And yeah, Austin, nice save on that last one. Good catch. But Jens, thank you for having us again. We always love being part of the Seattle Science Foundation. Looking forward to the next one and hope we provided good information for the audience. And thank you very much.
Again, you just have such a terrific team, and your fellows were outstanding as well. And I'm still not sure what to think about the topic in terms of what I'm going to do, but I still remain more posterior person for a flaw. So But I think that the subject is really so rich and so difficult to understand, and the subtleties really matter greatly. And we hit upon one thing, VTE prophylaxis, and we still have a consensus there. For instance, it seems to have a big impact. And the devil's in the detail, as I said, in terms of technique for deformity reduction, and both patient groups seem to be doing pretty well. Sig, Dr. Birch, Dr. Metz, any final thoughts from your end?
I think it's a really important topic. You know, to me, the predominance of evidence here is that single-stage surgery is the way to go, unless there's a compelling reason why not to. And again, the biggest reason I stage surgeries is if I'm getting posterior correction, and if I want to do something anteriorly just to get circumferential fusion down the road. But it's very, I think staging surgeries at a 3-day interval is very unusual. And I think it's done inappropriately in most instances. I think what we ignored is the financial incentives for surgery. I can't tell you how many cases I see of patients doing a 3-4 interbody anteriorly, then a day later doing 3-4 posteriorly. Some of that has to do with access surgeon availability, but it's rarely in the interest of the patient, and that's the elephant in the room.
Really good. Well, this will sign off. Great to see you guys. Learned a lot, although I'm still not sure what I'm going to do differently now. But I thought the subject matter was really rich and really desired and required further exploration. So thank you, Team UCSF. Thank you, Alekos, and your fellows and your wonderful co-faculty. Take care.
Thank you.
Yes. Good job.
Efjaristo.